I know you're addicted to my introject. I know you want videos to be as long as humanly possible. 1 hour, 2 hours, 6 hours. But being the sadistic narcissist that I am, I'm going to give you today a 10-minute video. Whet your appetite. I'm challenging myself. Can I encapsulate everything known about borderline personality disorder in fewer than 10 minutes? Let's see if I make it. Verbose as I am, mind you. Borderline personality disorder in 10 minutes and 10 questions. Number 1. Borderline personality disorder involves an identity disturbance, an unstable identity, a fragile sense of self. The borderline changes from one day to the next. She or he is irrecognizable. Her values, her beliefs, her behaviors, her traits, her preferences, her dreams, her wishes, her plans, everything changes. And it's like witnessing multiple personality disorder in action. Indeed, some scholars suggest that borderline personality disorder is a form of dissociative identity disorder, known as OSDD. Look it up. I have a video on this. Number 2. Borderline personality disorder and borderline personality organization involve emptiness. At the core of the borderline, there's a void, a black hole, very reminiscent of the narcissist. Exactly like the narcissist, the borderline has a false self. And identical to the narcissist, she has a fantasy defense. It's historical. Today, half of all borderlines are men. So, emptiness, false self, fantasy defense. In this sense, borderline and narcissism are indistinguishable from each other. Indeed, scholars such as Otto Kernberg have suggested that borderline is merely a reaction to narcissism, and that both of them, as character or personality disorders, are on the verge of psychosis. We'll come to it. Number 3, external regulation. The narcissist uses other people to regulate his or her sense of self-worth. The borderline uses other people, a special friend, favorite person, an intimate partner. She uses other people to regulate her emotions, to stabilize her moods. She outsources her inner landscape, her mind, to agents in the outside whose job it is to keep her on the level, balanced. They function as what is known as secure bases. Number 4, the borderline, again like the narcissist, has impaired reality testing. She misperceives reality. She misattributes and mislabels emotions and cognitions. She projects, she splits, she engages in primitive defense mechanisms. So borderlines are very prone to paranoia, for example. Paranoid ideation is very common in borderline personality disorder. Borderlines also overestimate the level of intimacy, love, and commitment in relationships. And in this sense, borderlines resemble and are reminiscent of histrionics. People, including clinicians and even scholars, often confuse and conflate borderline personality disorder with histrionic personality disorder, and with, as we shall see, borderline personality disorder with bipolar disorder. Borderlines, when pushed to the limit, under stress, rejection, duress, humiliation, endure and experience psychotic micro-episodes. For a brief moment, for a few hours, maximum for a few days, their reality testing is so short and so destroyed and so ruined that they become psychotic. They're unable to tell the difference between internal voices, internal images, and internal events, and external ones. Number 5, Borderlines are prone to self-harm, suicidal ideation, actual suicide. 11% of all people diagnosed with borderline personality disorder end up taking their own lives. Suicide is the leading cause of death among people diagnosed with borderline personality disorder. The borderline has self-destructive cognitions and engages in self-destructive actions, including self-trashing, reckless behaviors, impulsive behaviors, dangerous and risky behaviors. Now, all these forms of self-harm, and self-harm could be something like promiscuity even, or unprotected sex, or consumption of substances, abuse of substances. So all these self-harming and self-mutilation behaviors have four functions. They fulfill four functions. Number one, they're self-punitive. The borderline has inside her an internalized bad object, also known as a primitive superego. It is a constellation, a coalition of voices that inform the borderline that she's unworthy, she's unlovable, she's hateful, she's aggressive, she is wrong, she is stupid, she is ugly, etc. This is known as the internalized bad object. And then she punishes herself. She hates herself. She loathes herself to the extent of punishing herself through self-harming and self-mutilation. But self-harm and self-mutilation have other functions. For example, they silence the inner turmoil, inner tumult, and internal voices that torment the borderline. They create a distraction. The physical pain or the physical circumstances divert the attention of the borderline away from the chaos that is taking over her internally. Of course, self-harm, suicidal ideation, self-destructiveness also constitute a call for help. And finally, when the borderline mutilates herself, self-trashes and so on, she feels alive. Usually, she experiences herself as dead, a walking, talking corpse, dead inside. Self-harming and self-mutilation, suicidal ideation, make her come alive. Next, the borderline is reckless and impulsive. When confronted with stress, duress, criticism, rejection, abandonment, and humiliation, she may become a secondary psychopath, an impulsive psychopath. But she never loses her empathy, her positive emotions, and her sense of remorse and guilt for her acting out and dysregulation. Borderline is emotionally volatile. She has affective lability. She is emotionally dysregulated. It's a term borrowed from dialectic behavior therapy. She is mostly angry. Anger is a predominant hue, predominant color of the borderline's emotion. She has reactive moods and mood swings and mood shifts and changes whenever she is confronted with real or anticipated or impending doom and gloom, rejection, abandonment, and humiliation. Her moods change. She may become depressive. Her emotions take over her, drown her, dysregulate her. Most of them are negative. I mentioned anger and rage. She's affectively labile. The borderline maintains intense interpersonal relationships, which involve, exactly like the narcissist, involve idealization and devaluation. Borderline, therefore, is a relational disorder. Indeed, some scholars, such as Gunderson, suggest that borderline personality disorder is all about relationships. And finally, the borderline has twin anxieties: abandonment, rejection anxiety, also known as separation insecurity, and the opposing, diametrically opposed, engulfment and intimacy anxiety. So you can't win with a borderline. I hate you, don't leave me. She approaches you and then she avoids you. When she approaches you, she demands that you act as a secure base, a stable rock. Never abandon her, never let her go. But then when you do, as an intimate partner, when you become caring and intimate and loving and embracing, she feels suffocated, she feels consumed, she feels assimilated, she feels dead, and she wants to run away. She panics. And this is approach avoidance, repetition compulsion. She's terrified of abandonment and repetition compulsion. She's terrified of abandonment and rejection, so she approaches, and then she's terrified of the resulting intimacy and engulfment, so she avoids. Borderline personality disorder has been blamed on brain malfunctions, genetics, inadequate upbringing, social and cultural conditions, you name it. The truth is that the diagnosis of borderline personality disorder is 40 to 50% heritable. In other words, according to twin studies and adoption studies, heredity accounts for anything between 40 to 50% of individual differences in susceptibility to the disorder. What is inherited is described as temperament or character or disposition, and it affects mood and activity levels, attention spans, responses to stimulation, and so on and so forth. The other 50% is the environment. Nurture and nature collude in the case of borderline personality disorder, and this is why it can be safely diagnosed as early as age 12, as distinct from narcissism, which cannot be safely diagnosed before age 18. Borderline personality disorder is a challenge, but it is treatable, unlike narcissism. It is heterogeneous, and there are different clusters of symptoms in different people. But everyone who has borderline personality disorder, who suffers from it, shares the same components: a fragile self, impairment of relationships, impulsiveness, emotional volatility, and dysregulation. Psychotherapy is actually pretty effective in the case of borderline personality disorder, especially cognitive behavioral approaches, including dialectical behavioral therapy and psychodynamic therapies. So, borderline is treatable, and psychotherapy is the mainstay of treatment, but sometimes medication is given to take care of certain manifestations or aspects of the disorder. Borderline personality disorder is still, after 80 years, still being studied, still a work in progress, the knowledge is still evolving. The borderline is difficult to work with, and difficult to study, and difficult to be in a relationship with. Her moods are erratic. Her personal relationships are turbulent. She is unable to control anger. She has anger management problems. She is self-destructive. She is chronically angry, quick to take offense. She is suddenly depressed, irritable, anxious, or enraged for reasons which are beyond anyone. So it's quite a roller coaster. Drama is an integral part of borderline personality disorder, and actually it's a regulatory mechanism, an inevitable accompaniment to the pleasures of being with the borderline. Because on top of all this, the borderline typically is highly emotional, highly involved, highly empathic, loves like no one else, highly sexual, and all in all, a committed partner if you know how to be with her and work with her. For the benefit of my long-suffering students, this video contains in one location, in one place, all the latest research about borderline personality disorder. Cutting edge, bleeding edge, sadistic pun intended.
I reviewed the literature in the past 2 years. I assembled everything, and here you have it, the Borderline Bible. My name is Sam Vaknin. I'm the author of Malignant Self-Love, Narcissism Revisited. I'm a professor of psychology in CIAPS, Commonwealth Institute for Advanced Professional Studies in Cambridge, United Kingdom. I'm also a professor of psychology, or visiting professor of psychology in CU, Southeast European University, and I'm a former visiting professor of psychology for 5 years in Southern Federal University in Russia. Yes, the Russia that is becoming the United States' best friend ever, its bestie. Talk about borderline personality disorder. Okay, let's get serious. At the end of this video, I'm going to review the alternative model of borderline personality disorder in the text revision of the Diagnostic and Statistical Manual, 5th edition. But before we get there, let me summarize what we know hitherto. Borderline personality disorder is a pervasive disorder. It's pervasive in the sense that it insinuates itself and permeates every cognition, every emotion, every behavior of the individual afflicted. Generally speaking, we regard borderline personality disorder more behaviorally than otherwise. And the behavior is characterized by unstable interpersonal relationships, problems with self-image and affect, as well as impulsive, self-harming behavior. Now, the term borderline personality, actually borderline group, was first coined by Adolf Stern in 1938. He attempted desperately to describe a group of patients who were clearly not psychotic and, on the other hand, not neurotic. And so he said they belong to a border group or a borderline group. And so he coined this immortal phrase. Much later, in the 70s and 80s, borderline personality disorder was all the rage. Scholars such as Otto Kernberg have studied it in depth and have contributed immensely to our understanding. According to the Diagnostic and Statistical Manual of Mental Disorders, 5th edition, text revision in 2002, a diagnosis of borderline personality disorder requires the presence of 5 or more of the following characteristics or diagnostic criteria. Number 1, frantic efforts to avoid real or imagined abandonment. The Diagnostic and Statistical Manual neglects to mention engulfment anxiety, which is the twin anxiety in borderline. We have separation insecurity or abandonment or separation anxiety coupled with engulfment anxiety, and this leads to approach avoidant behaviors. The borderline seeks intimacy, craves love, yet when she gets these from her partner, intimacy, love, friendship, and presence, she recoils and she runs away. This is known as approach avoidance repetition compulsion. There is a fear of intimacy, actually. The borderline feels suffocated, shackled, imprisoned, incarcerated, coerced when she's confronted with a partner who is willing to satisfy her needs for closeness. And so this is a much neglected aspect of borderline personality disorder in the DSM. The second diagnostic criterion is a pattern of unstable and intense interpersonal relationships, characterized by alternating between extremes of idealization, in which a person assigns exaggeratedly positive characteristics to the self or to others, and devaluation, in which a person assigns exaggeratedly negative characteristics to the self or to others. This is commonly referred to as splitting. It's an infantile defense mechanism. The third criterion is identity disturbance or identity diffusion with a markedly and persistently unstable self-image or sense of self or self-concept. Impulsivity in at least 2 areas that are potentially self-damaging and reckless, Example, spending, sex, substance abuse, reckless driving, binge eating, and so on. Recurrent suicidal behavior, gestures or threats, or self-mutilating and self-harming and self-trashing behavior. Next is affective instability due to marked reactivity of mood. Now, that sounds very complex and very serious. It simply means that the borderline's emotions overwhelm her, and so she is emotionally unstable, volatile, whereas her moods cycle up and down between euphoria and dysphoria, depression and sometimes mania. So there is a reactivity of mood. Example, intense episodic dysphoria, irritability, or anxiety, usually lasting few hours and only rarely more than a few days. The next criterion involves chronic feelings of emptiness. I've dwelt on the issue of emptiness in borderlines and in narcissists. I've analyzed it and expanded on it using the writings of numerous psychoanalysts in a series of videos on this channel. Simply look for the word empty or emptiness. Inappropriate intense anger or difficulty in controlling anger. This is called externalized aggression. For example, frequent displays of temper, constant anger, recurrent physical fights. This should be distinguished from the reactive narcissistic rage in narcissists. And the last criterion involves transient stress-related paranoid ideation or severe dissociative symptoms. How many people are we talking about? What is the prevalence of borderline personality disorder? Well, the only reliable figures we have are from the United States, and there 2.7% of the population suffer from a borderline personality organization which is sufficiently severe to qualify as a borderline personality disorder. The figures are 3% for women and 2.4% for men, but this seems to be culturally biased, seems to be a culture-bound number. And in all likelihood, half of all borderlines are men. The American Psychiatric Association cites a lifetime prevalence of BPD in the United States as anywhere between 1.4% and 2.7%. In psychiatric settings, the estimate is 15 to 28%. In other words, anywhere between 15% and 28% of people who present themselves to a therapist or a psychiatrist in clinical settings is likely to have borderline personality disorder. Data from family studies have demonstrated that the prevalence of borderline personality disorder among first-degree relatives of affected patients is 4 to 20 times higher than in the general population. In other words, if you have borderline personality disorder, it's 4 to 20 times more, you're 4 to 20 times more likely to have a first-degree relative with borderline personality disorder than in the general population. This is a powerful indicator that there is a hereditary genetic component in borderline personality disorder. The ways in which the personality patterns of the borderline are generated are diverse, multifactorial. In other words, there is no single developmental path that leads inexorably to borderline personality disorder. Many factors interact. I've mentioned genetics, then we have environmental factors. In the pathogenesis of borderline, in other words, in the path that has led to the emergence of a pathology in borderline, we've identified, assuredly, childhood maltreatment, adoption, maternal separation, poor maternal attachment, dead mother, inappropriate family boundaries, including incest, parental substance abuse, sexual abuse, and serious parental psychopathology. Post-traumatic stress disorder often co-occurs with borderline personality disorder, and one therefore can speculate or surmise that borderline personality disorder is a post-traumatic condition. Eminent scholars, such as Judith Herman, the mother of complex trauma, CPTSD, and others, have suggested that borderline personality disorder, albeit marked mainly with emotional dysregulation, is actually a form of complex trauma. This is not accepted in the mainstream, but it is an interesting proposition. In my own work, much before Judith Herman actually, I have been proposing for well over 30 years that both narcissistic personality disorder and borderline personality disorder are post-traumatic presentations. Certain genetic factors, as I mentioned, probably play a role. We have data from twin studies that show that the heritability of borderline personality disorder is probably around 40%. Studies found a higher concordance of borderline personality disorder in monozygotic than dizygotic twins. So, how do these genes express? How do they manifest? What is it that they affect, especially in the brain? We know that there are alterations in the social reward and empathy networks of the brain caused by the dysregulation of the oxytocinergic system. And we believe, we are increasingly more convinced, that it somehow contributes to the emergence of borderline personality disorder. But again, to this very day, 100 years later, the emphasis is still on nurture rather than nature. The belief, common belief, among clinicians especially, who've been exposed to patients with borderline personality disorder, is that environmental factors are the crucial determinants of pathogenesis, the ones I've mentioned before. Clinicians should be aware that the Diagnostic and Statistical Manual provides two ways of diagnosing BPD. There is the copy-pasted list of 9 diagnostic criteria from the 4th edition, and there is the alternative model, which I will discuss at length a bit later. So we have a categorical model and a dimensional model. BPD conventionally to this very day, and I would add regrettably, is still diagnosed using a categorical model. In other words, the prospective patient either does or does not receive a diagnosis by meeting 5 out of 9 criteria. A dimensional model of diagnosis characterizes the condition based on a spectrum of prominent traits, which is a much more realistic and agile, versatile approach to mental illness. The 9 diagnostic criteria create a problem known as the polythetic problem. You could have 2 patients. Patient number 1 meets the criteria numbers 1, 2, 3, 4, and 5. So you have a patient, there are 9 criteria, and this patient satisfies conditions number 1 to 5. Then you have another patient, and this patient satisfies conditions 5, 6, 7, and 8. 5, 6, 7, 8, and 9, I'm sorry. So you have 2 patients, they're both diagnosed with borderline personality disorder, and yet they share only a single diagnostic criterion. In other words, the variance is enormous. Presentations vary significantly among patients having ostensibly the same condition. The categorical approach is often used with a dimensional, in conjunction with a dimensional approach, in an attempt to remedy this variation, to counter the polythetic or solve the polythetic problem. But I think the only correct approach is to forget the categorical list, the antiquated, may I add, categorical list, which is about 40 or 50 years old, and to move on completely to the dimensional model, which is a lot more descriptive and a lot more real life, a lot more realistic. One approach that may prove useful in performing a dimensional diagnosis of BPD is the five-factor model. The five-factor model describes personality on a continuum. And there are 5 characteristics: neuroticism, extraversion, openness to experience, agreeableness, and conscientiousness. I'm sorry, I've just added 3 days with 2 mega interviews each day. I don't have much of a voice left. And so it's been demonstrated that borderline personality disorder can be differentiated from other mental health conditions, or mental illness, or personality disorders, based on specific differences in 5-factor model traits. Similarly, in the International Classification of Diseases, 11th edition, which is the diagnostic textbook, diagnostic manual used by 80% of humanity, and is the main competitor of the DSM, there's a list of trait domains, and a combination of the trait domains. These combinations give rise to the equivalence of personality disorders in the DSM. Although borderline personality disorder shares many characteristics with bipolar affective disorders, they are entirely distinct diagnostic entities. But before I go there, because of the structure, the categorical structure of the DSM, especially the 4th edition, text revision, and the 5th edition, we have a situation where people are diagnosed with multiple personality disorders, combined with mood disorders, substance abuse disorders, anxiety disorders, and so on and so forth. It's very common for an individual attending therapy or clinical settings to end up being diagnosed with 6 or 7 or 8 conditions. That is untenable. Now, online, self-styled experts spew all kinds of nonsense. For example, that 40% of all borderlines are also diagnosed with narcissistic personality disorder. That is explicitly untrue. That's not correct. However, it is true that in about 1/3 to 40% of borderline personality disorder diagnoses, there is another attendant condition which could be a personality disorder, but more frequently is a substance abuse disorder or a mood disorder, a dual diagnosis. I want to focus on bipolar disorder because I'm shocked by the level of ignorance of clinicians and alleged scholars, especially in Europe, when it comes to the distinctions between borderline personality disorder and bipolar disorder. I have come across professors of psychology in, for example, Austria, clinicians in Austria, psychiatrists in Austria, who can't tell the difference between bipolar disorder or bipolar disorders and borderline personality disorders, confuse the two, and misdiagnose patients on a massive scale, industrial scale. This is really bad. It is true that both conditions, bipolar disorders or bipolar affective disorders and borderline personality disorders, it's true that in both conditions, there are dramatic shifts in mood. However, the timing, the duration, the intensity, the pattern of the mood shifts is very, very different. And in addition to that, there are clinical features in borderline personality disorders that never appear in bipolar disorders. Borderline personality disorder is characterized by affective instability. I'm quoting, a marked reactivity of mood. Example, intense episodic dysphoria, irritability, or anxiety, usually lasting a few hours and only rarely more than a few days. That's not the case with bipolar disorders. In bipolar disorders, there are episodes of affective extremes, highs and lows. And these episodes last for days as a minimum. Much more commonly, they last for weeks or they can take months. Patients with borderline personality disorder shift from euthymia, a good feeling, to anger, whereas patients with bipolar disorder tend to shift from depression to elation or from depression to mania. Although borderline personality disorder and bipolar disorders are different conditions, it is possible, of course, to have both of them. It's possible that they occur concomitantly in the same individual, but they're not the same disorder. Another differentiating factor between borderline personality disorder and bipolar disorders is sleep. There are sleep disturbances in both these conditions. Patients with borderline personality disorder experience an increased sleep onset latency, low sleep efficiency, and nightmares. Patients with bipolar disorders experience a reduced need for sleep, not merely disturbances in sleep or decreased sleep, but no need to sleep whatsoever during a manic episode. And on the contrary, during a depressive episode, they would experience excessive sleepiness, hypersomnia. So in these two realms, which are mood reactivity and sleep patterns, we already see massive differences between bipolar and borderline. And then, of course, there's a complete list of other clinical features which make an appearance in this diagnosis or that diagnosis, but not together, not in both. Clinicians should be aware of the egosyntonic nature of borderline personality disorder behaviors. We should make a distinction between behaviors and the outcomes of behaviors. Borderline personality patients report having experienced shame and guilt, remorse and regret. These are reported by borderline patients, and they're not reported, for example, by narcissistic patients or by psychopaths, of course. And yet the regret and the remorse and the shame and the guilt often revolve around the outcomes, the consequences of a specific behavior, not the behavior itself. As far as the borderline is concerned, the behavior is justified. All behaviors are justified. It's just the unfortunate outcomes of these choices, decisions, defiance, contumaciousness, rejection of authority, recklessness, the unfortunate outcomes of self-trashing, self-harming, harming others, externalized aggression. These outcomes are rejected. These outcomes are grieved over, mourned, and there are then negative effects such as shame and guilt. Personality disorders generally consist of egosyntonic patterns of behavior. Very few people with personality disorders reject their personality disorder. So a narcissist, for example, does not feel bad about being a narcissist. A borderline doesn't feel bad about being a borderline. Psychopath, of course, doesn't. So egosyntony is very common in personality disorders. And this is on the conscious level. Unconsciously, of course, in many of these personality disorders, there is an internalized bad object. In other words, unconsciously, there may be the feeling that the patient may possess the feeling that he or she is unworthy, a failure, a loser, ugly, stupid, unlovable, and so on. But that would be unconscious. Consciously, these people are happy-go-lucky, essentially. The problematic conduct exhibited by a borderline is not inherently distressing to the person performing it. The patterns may feel natural, justified, or even reflexive and instinctive. So, borderline personality disordered people, they're not ego-alien. They're ego-congruent. They're not ego-alien. In other words, their personality feels to them natural, acceptable. It is important, however, to make the distinction that the consequences of egosyntonic behavior may well become very distressing for such a patient, even if the performance of the behavior or the choice of the behavior is not distressing. So this distinction is very important when you diagnose borderline personality disorders. By contrast, mood disorders such as major depression or bipolar disorders, they're typically ego-dystonic. The behaviors are or ultimately become inherently distressing to the person who exhibits these behaviors or acts this way. So here is an important differentiating feature or criterion. Borderlines don't feel bad about their actions, they feel bad about the consequences of their actions. Whereas people with bipolar disorder feel bad about their actions. Personality disorders consist of ego-dystonic patterns of behavior, not ego-syntonic patterns of behavior, not ego-dystonic ones. Okay. How do we treat borderline personality disorder? Not with medication. That's a common misconception, especially online. There are no medications approved by any authority that I'm aware of, definitely not by the FDA in the United States. There are no medications specific to borderline personality disorder, although there are medications which treat features of borderline personality disorder, such as, for example, depression or ananchestia, obsessive-compulsive features. Typically, borderline personality disorder is treated with different forms of psychotherapy. There are many approaches to borderline personality disorder, and most of them, what is common to most of them, for example, schema therapy and so on, is to emphasize the self-efficacy, the sense of self-efficacy and sense of self-worth of a patient. So they teach patients, these treatment modalities teach patients to recognize what triggers their affective reactions. Patients are also encouraged to connect actions to thoughts, to feelings, to consequences. A sequence that is often disrupted in borderline personality disorder, narcissistic personality disorder, and other personality disorders. One frequently recommended approach is, of course, dialectical behavior therapy, DBT. This is by far the most efficacious method or treatment modality we have with borderline personality disorder, and the recommended one, by me as well. Dialectical behavior therapy is widely used, and effective forms of cognitive behavior therapy that where we treat borderlines resemble dialectical behavior therapy. Technically speaking, dialectical behavior therapy is cognitive behavior therapy modified, because it involves also a group setting. The DBT targets suicidal and self-harming behavior using 8 treatment strategies. Number 1, dialectical strategies foster the patient's ability to accept reality as it is. Borderline personality disorder, as much as narcissistic personality disorder, is about the rejection of reality, or at the very least, the outsourcing of reality to an intimate partner or a special person. Owning reality, accepting it, living in it, is a crucial treatment plan goal. Therapists accomplish this through the use of myth and paradox, a focus on reality as constantly changing, the non-resolution of ambiguity, learning to live with ambiguity, be comfortable with it, and cognitive challenging and restructuring. The second element in DBT is problem solving, a variety of strategies that support the patient's ability to recognize sources of distress and address them in an adaptive way, not a maladaptive way. Validation strategies utilize empathy, non-judgmental acceptance, and the patient's own resources. Irreverent communication strategies call for the therapist to respond in a matter-of-fact, irreverent way to the patient's suicidal tendencies, not to panic, definitely not to chastise or criticize the patient, not to react in any emotional way, but to deal with the suicidal ideation and sometimes with suicidal threats matter-of-factly, with a cool head and with irreverence, not to elevate or the suicidal act or the suicidal ideation into some kind of ideology or religion to give it respect. Such strategies are in direct contrast to validation strategies. Consultant strategies emphasize the therapist's role as a consultant to the patient. The therapist in DBT has an active role. He doesn't just sit back. He doesn't just mirror the patient, but the therapist in DBT is a friend of the patient, an active participant in the patient's life. The therapist, for example, gives the patient advice. It's a partnership in the full-fledged sense, and in many ways the therapist becomes a consultant to the patient, but also kind of friend by proxy or vicarious friend. The idea is for the therapist to work with the patient in a way that creates some kind of emotional alliance. So the consultant, in the case of DBT, is less attuned to other treatment professionals, which may be dealing with the patient, and more to the patient, is more on the patient's side. Capability enhancement strategies serve to keep patients engaged in acquiring and practicing skills required to cope with everyday life. Everyday life in borderline personality disorder is very overwhelming and may lead to mood disorders and substance abuse disorders and so on. So teaching the borderline patient skills on how to deal with daily life and how to develop self-efficacy and how to obtain outcomes which are either desired or beneficial, this is a crucial aspect of DBT. Relationship strategies emphasize building a strong patient-therapist relationship, as I've mentioned. And the belief is that addressing interpersonal problems within this relationship between therapist and patient as they arise, learning to apply these skills to other relationships in the patient's life might ultimately lead to the permanent, lifelong acquisition of the ability to interact with other people in ways which are not dysfunctional or harmful. So, in other words, the relationship between the patient and the therapist or the consultant in DBT is the prototypical relationship. The patient then learns to take this relationship and all the lessons that it had wrought and apply it to other relationships where the consultant is absent. It is, in a way, a reenactment of childhood, where the patient is allowed to grow through the interaction with the consultant. The consultant fulfills the equivalent of a parental role. Contingency strategies involve the therapist being upfront with the patient about what outcomes reasonably can be expected from the therapy. There's no exaggeration of the potential benefits of the therapy. So, borderline personality disorder may be treated adjunctively with medication when appropriate. There are no medications approved. I repeat this. It's not true what you hear online, that there are cures for borderline personality disorder, let alone narcissistic personality disorder. There is a broad spectrum of pharmacologic agents, psychopharmacological medications that can be used to address specific symptoms or presentations. For example, antidepressants. There's been a review of randomized controlled trials, and they found that certain antidepressants were effective in decreasing symptoms of depression, hypersensitivity in interpersonal relationships, and obsession in patients with borderline personality disorder. Sertraline, I think, was one of them. Among mood stabilizers, topiramate and lamotrigine and so on and so forth, they were shown to reduce anger in patients with borderline personality disorder. Even antipsychotics, olanzapine, for example, were found to reduce anger, paranoia, anxiety, and interpersonal sensitivity in patients with borderline personality disorder. Again, coming back to the core clinical observation. Treating borderline with medications has limitations, not small limitations. Whereas some patients with borderline may respond to various medications initially, very few respond satisfactorily over an extended period. Specifically in borderline personality disorder, medications are even less effective than in the general population or in other conditions. The duration of pharmacological treatment should be time limited. There should be an ongoing review, and then the medication should be stopped when it's no longer effective. Borderline personality disorder is a lifelong condition, but the prognosis varies widely. We know that there is spontaneous healing or spontaneous losing of the diagnosis later on in life. We know that DBT is very effective. Diagnostic criteria and standards have changed over time, and presentations may vary widely among patients. So predicting outcomes with precision is very difficult. Research has shown that early onset borderline is associated with poor functioning in adolescence. We know that much. So if someone develops symptoms of borderline personality disorder around the age of 12, the adolescence of such a person is likely to be highly chaotic and disturbed and dysfunctional and problematic. Evidence also suggests that the course of adolescent onset borderline is similar to that seen in adult populations. In other words, the later the borderline develops, the later the borderline disorder develops, the better the prognosis. The rate of suicide associated with borderlines is estimated to range between 3% and 10%, depending on the cohorts and the populations and the age groups and the countries and the cultures and the societies and the religious affiliation and so on and so forth. We could generalize and say that the rate of suicide in borderline personality disorder is definitely closer to 10% than to 3%. Many people who qualify for a diagnosis of borderline personality disorder also commit suicide before presentation, before they've attended therapy, before they presented themselves to a clinician. We strongly suspect that suicide is highly associated, highly correlated with borderline personality disorder in non-diagnosed people. People go through life sometimes without ever coming to clinical attention. It's not uncommon to diagnose borderline personality disorder in one's 30s or 40s or even 50s. Evidence indicates that early diagnosis and intervention improve patient outcomes. The prognosis for borderline personality disorder is good if you begin to work on yourself and attend, for example, DBT early on, like in your 20s or your teens even. Unfortunately, borderline personality disorder very rarely presents in its purity. It's very rarely unadulterated by other conditions. So most people with borderline personality disorder, for example, abuse substances. The comorbidity there is very high. And these people have an increased risk of suicide. Substance dependence, substance abuse is commonly observed in patients with borderline personality disorder, and higher rates of comorbid psychiatric disorders are also seen in patients with BPD, including mood disorders, particularly major depressive disorders, anxiety disorders, and eating disorders. Patients with borderline often experience sleep disturbances, as I mentioned. And so the picture is complicated, severely complicated, by these comorbidities. Let us now try to explore the new approach to borderline personality disorder that is embodied in the Diagnostic and Statistical Manual in the alternative model of borderline personality disorder, which is dimensional. I'm going to read to you what the DSM Alternative Model has to say, because I think every word counts. It's a distillation of the latest knowledge. It's regrettable that clinicians still use the DSM-4's list of bullet points because it's antiquated, does not reflect current knowledge, and does not capture many aspects of borderline. So here it is, the alternative model. Typical features of borderline personality disorder are instability of self-image, personal goals, interpersonal relationships, and affects, accompanied by impulsivity, risk-taking, and/or hostility. Characteristic difficulties are apparent in identity, self-direction, empathy, and/or intimacy, along with specific maladaptive traits in the domain of negative affectivity and also antagonism and/or disinhibition. Proposed diagnostic criteria in the alternative model. A. Moderate or greater impairment in personality functioning manifested by characteristic difficulties in 2 or more of the following 4 areas. Area number 1, identity. Markedly impoverished, poorly developed or unstable self-image, often associated with excessive self-criticism, chronic feelings of emptiness, and dissociative states under stress. Number 2, self-direction. Instability in goals, aspirations, values, or career plans. Number 3, empathy. Compromised ability to recognize the feelings and needs of others associated with interpersonal hypersensitivity. In other words, prone to feel slighted or insulted, hypervigilance. Perceptions of others selectively biased toward negative attributes or vulnerabilities. And field number 4, intimacy, intense, unstable, and conflicted close relationships, marked by mistrust, neediness, and anxious preoccupation with real or imagined abandonment. Close relationships often viewed in extremes of idealization and evaluation, and alternating between over-involvement and withdrawal. B. 4 or more of the following 7 pathological personality traits, at least one of which must be impulsivity, risk-taking, or hostility. Number 1, emotional lability, an aspect of negative affectivity. Unstable emotional experiences and frequent mood changes. Emotions that are easily aroused, intense, and/or out of proportion to events and circumstances. Number 2, anxiousness, an aspect of negative affectivity. Intense feelings of nervousness, tenseness, or panic, often in reaction to interpersonal stresses. Worry about the negative effects of past unpleasant experiences and future negative possibilities. Feeling fearful, apprehensive, or threatened by uncertainty. Fears of falling apart or losing control. Number 3, separation insecurity, an aspect of negative affectivity. Fears of rejection by and/or separation from significant others, associated with fears of excessive dependency and complete loss of autonomy. Number 4, depressivity, an aspect of negative affectivity. Frequent feelings of being down, miserable, and/or hopeless. Difficulty recovering from such moods. Pessimism about the future. Pervasive shame. Feelings of inferior self-worth. Thoughts of suicide and suicidal behavior. Number 5, impulsivity, an aspect of disinhibition. Acting on the spur of the moment in response to immediate stimuli. Acting on a momentary basis without a plan or without consideration of outcomes. difficulty establishing or following plans, a sense of urgency and self-harming behavior under emotional distress. Number 6, risk-taking, an aspect of disinhibition. Engagement in dangerous, risky, and potentially self-damaging activities, unnecessarily and without regard to consequences. Lack of concern for one's limitations and denial of the reality of personal danger. And finally, hostility, an aspect of antagonism, persistent or frequent angry feelings, anger or irritability in response to minor slights and insults. And this delectable picture, clinical picture, encapsulates perfectly all the aspects, psychodynamic and behavioral, of the borderline patient. Have fun.
It sends Professor Sanwaknin Day again, and he is a pioneer of narcissistic abuse and the author of Malignant Self-Love. And I hope this will be translated in Turkish soon. And today we will talk about narcissism, narcissistic personality disorder, and borderline personality disorder, because in society they are confusing these illnesses. First, can we talk about the narcissistic personality disorder and the differences between borderline?
Yeah. Thank you for having me. Good morning, Shoshanim. And a warning, this is going to be a long answer because there's a lot to say. You're completely right that there is a huge confusion between borderline personality disorder and narcissistic personality disorder. And why is this important? Because many victims of narcissistic abuse actually have borderline personality disorder. And many abusers actually have borderline personality disorder, not narcissistic personality disorder. And if you get it wrong as a clinician or as a member of the public or as a victim even, then the whole attitude is wrong and the outcomes are wrong. A proper diagnosis is the precondition for healing, of course, but also for management. To manage a relationship, to manage a therapeutic process, to manage an interpersonal interaction, to manage the workplace, you need to diagnose people correctly. The differences between borderline personality disorder and narcissistic personality disorder are not small. They're pretty substantial. So first of all, borderline personality disorder was first described by Adolf Stern in 1938, a long time ago.
Oh.
He didn't call it borderline personality disorder, he called it the borderline group. So this was Adolf Stern in 1938. Then between the 1930s and the 1980s, there were many studies about borderline personality disorder. It was the heyday of these studies, and so we had people like Otto Kernberg and others, and we had, of course, Kohut on the side of narcissism. And at that point in time, many prominent scholars believed that there is a deep relationship between borderline personality organization, borderline features, borderline traits, borderline behaviors, borderline dynamics, and narcissism. They believe that there is a profound etiological connection. In other words, there's something that leads to both conditions emerging simultaneously. Kernberg suggested that borderline is a defense, narcissism is a defense against borderline. He said, initially the person develops borderline and then it's terrifying, and so the person defends against the borderline condition by becoming a narcissist.
Then every narcissist can be also borderline, we can
No.
say like this?
Not every narcissist can be borderline, because once you acquire the narcissistic defenses, they take over and they eliminate the borderline.
Okay.
There are, of course, people who are both borderline and narcissists. Of course, there is what we call a comorbidity, borderline and narcissism. It is not 40%, like self-styled experts are saying. There's a lot of nonsense online. One should be very careful. But yeah, there is a comorbidity of this kind. Grotstein, who was another psychoanalyst, suggested that a child who is exposed to abuse and trauma becomes more and more borderline. And then at some point, the child says, I cannot tolerate this borderline condition. I want to become a narcissist. And the child attempts to become a narcissist. If this transition from borderline to narcissism fails, the child remains stuck in the borderline phase and will develop borderline personality disorder. If it succeeds, the child will eliminate the borderline, defend against it very efficiently, bury it in the unconscious, and will become a full-fledged narcissistic person. And that's why Grotstein says that the borderline is a failed narcissist, someone who tried to become a narcissist and failed. So this is generally the general overview of the connection between them. But when we look at the clinical picture, when someone comes to a clinic to get some therapy, or when someone needs to be diagnosed, for example, in court settings or in prison, or when someone needs to be, has undergone some kind of massive crisis and needs to be diagnosed, what we do, we look at what we call clinical features. We look at behaviors, we look at dynamics, we look at emotions, we look at cognitions, and so on and so forth. And now I will go into the differences between the two conditions. We start with the elements of borderline which exist in all types of borderline. There is no borderline personality disordered patient alive without these features. There are other features which appear in some borderlines and don't appear in other borderlines. But the ones I'm going to describe right now appear in all borderlines. So the first thing is emotional volatility, emotional dysregulation. This is called affective instability. That is when emotions, negative and positive, overwhelm the borderline, disable the borderline. The borderline becomes paralyzed. It's as if the borderline perceives emotions as threatening, and then the borderline freezes. She freezes. And it's a kind of defense against this situation. So all borderlines have this. All borderlines cope very badly with emotions. Emotions disable, paralyze them. The second element, which is common to all borderlines, is mood lability, ups and downs, cycling, and so on. Now, this is not to be confused with bipolar disorder. In bipolar disorder, we also have cycling between depression and mania, or elation, or euphoria. So we have this. But there are massive, big differences between bipolar disorder and borderline personality disorder. They are not the same condition, as many European so-called scholars and so-called clinicians, they make this mistake very often. I was in Austria recently, and I'm sorry to say, but the so-called professionals there confuse BPD and bipolar. So this is very serious confusion. Bipolar disorder is a mood disorder. And the difference between bipolar disorder and BPD is that the cycles of depression and mania are much longer in bipolar. They can last months, sometimes years. Whereas in borderline personality disorder, the cycles are much faster, and typically they are between 4 hours and 4 days, but never longer. Second difference, the sleep patterns in bipolar disorder are dramatically different to the sleep patterns in borderline. In borderline, the borderline patient finds it very difficult to fall asleep, finds difficult to maintain sleep, has insomnia and so on. Whereas the bipolar patient simply does not want to sleep. Is against sleeping, doesn't want to sleep.
They resist sleeping. They resist sleeping.
When they're in the manic phase. In the manic phase, the bipolar resists sleeping, does not want to sleep. And in the depressive phase of bipolar disorder, the patient is hypersomniac. In other words, this kind of patient sleeps 20 hours a day. That is in bipolar, not in borderline. In borderline, there's a constant state of sleep dysfunction, constant state of insomnia, or the sleep is always disturbed in the same way. So mood lability. Next thing is the intensity of the interpersonal relationships. Here is a major source of confusion. Both the borderline and the narcissist idealize, overvalue, and then devalue. Both of them.
The same cycle.
Same cycle, identical. The interpersonal pattern of relationship in borderline is indistinguishable, totally identical to the pattern of relationship in narcissism. They cannot be told apart. However, what is different is the intensity. Whereas in narcissism, the shared fantasy that dictates the cycle of the relationship is very robotic, very automatic. It's as if the narcissist is going through the motions, is not really in it, is not really involved in it. It's like acting. It's like going through, okay, phase 2, okay, phase 3. What can I do? I have to go through it. It's as if the narcissist is one step removed from the relationship. He's like observing maybe the relationship. So you could see in narcissism a pattern of detachment. Whereas in borderline, the relationship is super intense. The intensity is enormous. It's fire, it's brimstone, it's uncontrollable, it's dramatic, super dramatic. So this is common to borderline, actually, not to narcissists. And the intensity is a differentiating feature between narcissism and borderline. But in this relational disorder, this is called relational disorder. In this relational disorder, the borderline also starts by love bombing, devaluing, idealizing, and then devaluing the partner. In this sense, it's the same. The splitting defense in borderline is the same as a splitting defense in narcissism. So that's what allows the borderline to idealize. You're all good, you can do no wrong, you're perfect, you're amazing, you're unprecedented, I've never had anyone like you, and so on. And then immediately transition to, I hate you, you're horrible, everything you do is wrong.
And they're all real emotions at that time.
All this is perceived as authentic or ego, not ego alien, ego congruent. So the borderline perceives all this as real, coming from the inside, and so on and so forth. But in her case, in the case of the borderline, it's much more, as I said, dramatic and intense than in the case of the narcissist. And this is why it's very difficult for victims of narcissistic abuse, because the narcissist treats you, when you're the intimate partner, treats you as kind of object. You're objectified, kind of. Yes, he will love bomb you and idealize you, but you always have a feeling that it's not really about you. The idealization in the case of narcissism is about the narcissist and about the process. The narcissist is like invested in the process, not in you. It could be anyone. There's a feeling that it could have been anyone. It didn't have to be me as the intimate partner, but it could have been anyone.
Yes.
And very often, victims of narcissistic abuse discover that the narcissist repeats the same pattern with the same behaviors, with the same sentences, with the same words, with multiple potentials, sometimes at the same time.
At the same time.
Because there's no attachment, there's no what we call cathexis, there's no emotional investment. Whereas in borderline, the emotional investment, the cathexis is very clear, very powerful, overwhelming, consuming. The drama is operatic, like opera. It's a production, some major production, and so on and so forth. In borderline, we have something that we don't have in narcissism, and that is what we call the twin anxieties. We have a combination of abandonment anxiety. By the way, abandonment anxiety or separation anxiety is not the clinical term. The clinical term is separation insecurity. So we have abandonment anxiety on the one hand, and we have engulfment anxiety. So what happens with the borderline, she seeks intimacy. She wants love. I say she, let it be clear, half of all borderlines are men. And half of all narcissists are women. But I'm using she because of historical reasons.
Yeah.
So the borderline would look for love, for intimacy, for immersion, for merger, for fusion, for symbiosis, a twin flame, a soulmate, a reflection, a copy, a clone. She would look for something like that. And then she would approach, and she would experience this reaction from the partner. And if the partner reciprocates, provides this intimacy, affords this love, the borderline panics. She panics. She feels suffocated. She feels shackled, imprisoned. She feels she's dying. And then she runs away. Avoidance. So we call it approach, avoidance, repetition, compulsion. Because it's compulsive. She cannot help it. So the borderline, on the one hand, has severe abandonment anxiety. She's terrified of rejection, of being ignored, of criticism, well, exactly like the narcissist in this sense. But she has something the narcissist does not have, engulfment anxiety. And consequently, she cycles. And so this is the famous, I hate you, don't leave me. I hate you, don't leave me. Yeah.
Then I will ask you something. When the relation is very good and very nice, then one type of anxiety starts. When the relation is going bad, another type of anxiety
Yes, she's
starts.
always.
In anxiety.
Always. Anxiety is the background noise of borderline. The borderline is constantly anxious. She anticipates rejection, humiliation, abandonment, and she panics. And then she behaves in ways that cause the abandonment, because she becomes clinging, or she becomes aggressive, or she becomes demanding. But if this doesn't happen, if she has no reason to anticipate rejection and abandonment because the partner is in love, and then she panics, because that means she's going to disappear. Borderline is about merger, about fusing with the partner, becoming one with the partner, like going back to the womb. It's symbiotic. It's creating a single organism with two heads. And this is a terrifying experience because it means that she has to disappear. The borderline hands over, outsources her mind to the intimate partner. She tells the intimate partner, from this moment on, you have perfect control over me. You can regulate my moods. You can make me happy. You can make me depressed. I'm giving you this power. You can regulate my emotions. A smile from you would change my emotions. If you criticize me, you can change my emotions. So you have total power over me. She hands over agency, total power. And that, of course, creates panic. Because if someone is in total control of you, total ownership of you, if someone is your master, that means you're the slave. Means you're a slave. And that is a terrifying thought, because what if the partner suddenly loses interest or abandons you? What if the partner is evil and is going to abuse this access and this power and torture the borderline? There are all kinds of scenarios. The borderline has enormous imagination. So there's all kinds of scenarios. And she panics and she runs away. She destroys, she undermines the relationship. She sabotages the relationship in a variety of ways. She could cheat. She could engage in infidelity. She could triangulate. Triangulation means you introduce a third party into the relationship and in order to provoke the intimate partner. She could literally undermine and sabotage the goals of the intimate partner. She could even place the intimate partner in at risk by, I don't know, going to the police or to the tax authorities and snitching on the partner. There's no end to what she can do in order to destroy the intimate relationship, because what threatens the borderline?
But that doesn't just give harm to the people, and it doesn't just give harm to the relation. Then she can give harm to the person also.
One way to get rid of
legally.
One way to get rid of the relationship is to get rid of a partner.
It's a border.
When you get rid of a partner, there's no relationship. It is the relationship that threatens the borderline. Another thing in borderline, which is less common in narcissism, is anger. Not necessarily rage, but anger. With narcissism, we have narcissistic rage. But narcissistic rage is reactive. If you disagree with the narcissist, criticize the narcissist, humiliate the narcissist, and so on and so forth, the reaction might be, not always, narcissistic rage. In borderline, the background is anger. Like anxiety, exactly like anxiety, the anger is always there, very close to the surface. It's very easy to provoke the borderline. And she is constantly angry. And this anger manifests in outbursts, but she can also be passive-aggressive, or she can be angry as a state of mind. She could be constantly angry. It's an angry person. You know, anger is a crucial element in borderline. It's inappropriate, and it's uncontrolled, and it defines the borderline. And finally, another psychological feature of all borderlines. So everything I just described is common and valid for all borderlines.
Basic borderline.
All types, yes. These are the clinical features which are common to all borderlines. So, and the last one is emptiness. The borderline feels empty inside. She feels a void. She feels like she is a black hole. And she has to fulfill this emptiness somehow. So some of them fulfill the emptiness with theatrics and dramatics. Some of them hope to fulfill the emptiness via the intimate partner. This kind of borderline might say, "You are my world, you are my life, I'm living for you." You know, the borderline develops a multiplicity of techniques to cope with the emptiness and to fulfill it somehow, because the alternative is to experience the emptiness, which leads usually to self-harm, self-mutilation, cutting, and so on, and suicidal ideation. Depending on the population of borderlines, between 3% and 11% of borderlines die of suicide. That's a huge number. It means that 1 of every 10 borderlines would end his or her life. And that is the leading cause of death among borderlines. Suicide. Not cancer, not heart attack, but suicide. Okay. So these are the core features of borderline. Now let's talk about other clinical features which are common, but you could be a borderline without them. These clinical features. You could be diagnosed with borderline and not have these features. You cannot be diagnosed with borderline unless you have the features that I mentioned until now. These are minimum requirements to be diagnosed. But now there's many others, and we'll talk about them. Again, I will compare all the time to narcissists. Yes.
Okay.
Number 1 is identity disturbance or identity diffusion. The borderline's identity is not stable. So on Monday, she has some values, she has some beliefs, she's committed to a certain course of action, she has plans for her life, she has attitudes, she has motivations. That's on Monday. On Wednesday, she will be the exact opposite than Monday. So on Monday she could say, people who cheat on their spouses should be executed. I hate cheating. There's nothing worse than infidelity. Then on Wednesday she will go to a bar, she will pick up a stranger and she will cheat with him. So that's an example of what we call axiological shift in values. But also beliefs. She can say on Monday, I believe in God. Definitely God is managing my life. I find solace and comfort in God, and so on. And then on Wednesday, she will espouse the most extreme form of atheism, and so on. So there's no stability, not in values, not in beliefs, not in attitudes, not in motivations. Of course, her plans change all the time. On Monday, she wants to go to study agriculture. On Wednesday, she decided to be a mathematician. And on Friday, she would be a traditional wife and housewife. Of course, until next Monday, when she would want to become an astronaut. Yeah?
Are they aware of these shiftings?
Not really, because one major problem with borderline, and that is opposed to what people believe, is that borderlines are egosyntonic. In other words, borderlines feel comfortable with who they are.
Oh.
Now, that's very important distinction. A borderline might feel guilty or ashamed for what she had done. She might also feel distressed, disappointed, and angry because of the consequences of her actions, the outcomes. But when it comes to herself, she feels good with who she is. She's egosyntonic. She actually is grandiose. Borderlines are grandiose, exactly like narcissists. So she would regard herself as superior in some way. Super beautiful, drop dead gorgeous. She's gorgeous and you drop dead. All kinds of, she would aggrandize herself in her own mind, and so she is egosyntonic. And in her mind, these shifts in identity, these cataclysmic transitions, are fully justified. She would say, for example, yeah, I wanted to study agriculture on Monday, but then I did some search online and there's no future in this. So that's why now I want to be an astronaut. Because I think astronauts will go to Mars with Elon Musk, and so I want, this kind of thing. She would invent some
they can
stupid...
find excuses very easily.
Yeah, some story. Okay. So identity diffusion or identity disturbance is pretty common in borderlines, but not in all. Next is dissociation. More extreme borderlines where the personality organization is seriously disturbed, where actually the personality is not put together at all, is kaleidoscopic, broken, shattered, fragments. This kind of borderline, the extreme end of the spectrum, would usually have dissociation. She would dissociate when she finds herself in a situation of stress or extreme anxiety. For example, when she anticipates rejection or humiliation or experiences abandonment. Or in these conditions, she falls apart. She goes through a process called decompensation. All the defenses crumble or are disabled, and she remains without a skin. It's like she doesn't have a skin. She's in direct touch with reality and has no defense, no firewall, nothing. At that point, she has essentially only one option. She acts out. She externalizes aggression in some way. There's a lot of aggression, anger that is boiling and building and so on. There's a lot of fear, anxiety. And so to somehow get rid of these emotions, she would act out. She would do something crazy. But because whatever she is about to do is socially unacceptable and she hates some of her actions, she would later feel bad, guilty, ashamed. She knows it. So she would do it and forget about it. But I mean forget. Not,
really forget.
She's not pretending. She simply is not there. So we have three types of dissociation in borderline. We have amnesia, simply forgetting what happened. So she could sleep with a stranger, on a one-night stand, and she would not remember it. Even when she's confronted with evidence and so on, she would be shocked. She would not have no recollection of the event. Even when she's not drunk. She could derealize. Derealization is when she does something, but it feels like a movie. It feels unreal. And depersonalization is when she does something, but she feels that she is not there. So her body is there, and someone is penetrating her or doing something to the body. She has left her body. She is not there. So these are all forms of dissociation. And dissociation is common in more extreme cases. Similarly, in more extreme cases, we have a very dangerous process actually, which is paranoid ideation. More extreme borderlines become paranoid easily. And then when they become paranoid, and because borderline is a disorder of aggression, when they become paranoid, they become positively dangerous, absolutely dangerous. If the borderline identifies you as a threat, she may wish to take you out somehow, poison you, kill you, do something, just to reduce the anxiety. So externalized aggression in extreme borderline is anxiolytic. It reduces anxiety. None of the things I described applies to narcissism. Narcissists don't have identity diffusion, at least not in the borderline way. They don't dissociate. Narcissists don't dissociate only under stress, like borderline. They dissociate all the time. Narcissists have paranoid ideation, but only when they collapse. The paranoia is a form of grandiosity. I'm important. People are conspiring against me. People have malevolent intentions because I'm very crucial, I'm very superior. People envy me, so they want to. So this is the narcissism type of paranoia. But in narcissism, paranoid ideation is pretty limited to the collapse, and is never aggressive. Paranoia would not lead the narcissist to act against anyone. And so the differences are very important. Next is the fact that both narcissists and borderlines have a false self. This is something that people don't know. They think only narcissists have a false self. It's not true. Borderline also has a false self. And similarly, the borderline is grandiose, exactly like the narcissist. And similarly, she has a fantasy, exactly like the narcissist. So what's the difference? These are critical features in narcissism. And if the borderline has all of them, maybe it's true that borderlines are narcissists. The answer is no, because the content of the false self and the content of the fantasy and the content of the grandiosity are very, very different
Their fantasies
to
are
narcissism.
different.
Yes. Whereas in narcissism, the fantasy is about the narcissist, the grandiosity of the narcissist. The fantasy in narcissism is what we call self-enhancing. It's a fantasy that makes the narcissist bigger in some way, more intelligent, more. So a narcissist could have a fantasy that he's a genius. That would be a classical cerebral narcissist fantasy. Or a narcissist could have a fantasy that is sexually irresistible. That's also a typical narcissistic fantasy. But the fantasy is about self-enhancing, the cognitive distortion, the grandiose narrative, the grandiose self-concept of the narcissist, which is inflated and unrealistic and counterfactual. In borderline, the fantasy is about the partner, not about herself. The fantasy is not a reimagining of the borderline. It's not about the borderline. The typical fantasy of the borderline, I found him. I found the one. He is going to be my rock. Now, someone knows me like no one else. Someone can therefore, because he knows me and loves me, because of course it's all dramatic, the love is intense and amazing and never before, and so on. So now this person will be able to reach into my mind and regulate my emotions, stabilize my moods, and generally make me harmonious, in harmony, make me feel at peace with myself, inner peace, reduce my anxiety, take away my anxiety. I will not be anxious anymore. Wonderful. I found instant therapy in the intimate partner. So the borderline's fantasy is exteriorized. It's a fantasy about someone else.
Can they fall in love very easily? Like, for example, the narcissist can change their supply very easily. Can borderline do that too?
Yes.
Then
both of
they
them,
can find their real love so
Yeah.
much.
but both narcissists and borderlines don't love.
Yeah.
This is not love, of
It's
course.
their fantasy.
It's
but,
fantasy.
But as you said, she thinks that she found the one, then she can find too many ones.
Yes, she can.
in
The difference
platform.
between borderline and narcissist is the discard phase. Whereas the narcissist discards offhandedly, instantaneously, and without any visible emotion. Just discards, like so much trash. You're no longer useful, or you contradicted the shared fantasy, or you criticized the narcissist, or you deviated, diverged from the internal object that represents you in the narcissist's mind, and so on. So you're all bad, you're devalued, narcissist splits you, you're all bad, and as an all bad, corrupt object, the narcissist throws you to the garbage, the same way he would throw to the garbage a battery that is finished, or a smartphone that's no longer working. So the discard in narcissism is callous, is cruel, is cold, is calculated, objectifies the discarded person, and so on. Whereas the borderline does not do it this way. The borderline approaches and avoids, and she would do it many, many times before she gives up on the partner.
Oh.
She would approach the partner and run away and come back and try again, and she doesn't give up on the partner very easily. Once she has given up on the partner, she immediately finds an alternative, exactly like the narcissist.
First they find someone and jump to
Not
another
always.
one.
Not always.
They can give time.
Sometimes yes, sometimes no.
Uh,
But that's in healthy people also.
Narcissists seek revenge or borders seek revenge? Because there are, I think borders can seek
Revenge is more common in borderline because borderline is much more aggressive than the narcissist. Revenge is most common among borderlines and psychopaths. Less common in narcissism. And that's a form of aggression, simply.
And I want to ask you something, as you answered before, but in generally we think that narcissists are men, borders are women. But here you told that there are 50% in average. What are the differences between the men and women, border women and border men?
There are no psychological differences. There are no psychodynamic differences between narcissistic men and narcissistic women, borderline men and borderline women. They are identical as far as psychology, clinical psychology. However, society, culture, informs women and men how to behave. This is called gender roles. There are gender roles. There are expectations, social expectations. There's a process of socialization. There are all kinds of social cues. There are all kinds of social sanctions if you misbehave. If you're a woman and you behave as a man, you would be punished. If you're a man and behave as a woman, you would be punished. So there are great incentives to conform to gender roles. Now, of course, gender roles change all the time, no question about it, but it's not true that gender roles have been eliminated. That's complete nonsense. They've just been transformed massively. The pathology would express itself via the gender role. So the pathology conforms to the gender role. A woman in a traditionalist society, conservative society, patriarchal society, her narcissism would express itself through her children. She would brag about the children. She would boast with the children. The children would be the sources of supply in such a society. Or she may be a perfect housewife or a perfect mother or a perfect wife, and she would be ostentatious about it. She would brag about it. She would inform everyone that she's perfect and so on. That's an example of manifestation of narcissism in traditionalist society with women. A man in this society may be, for example, ambitious and competitive, or maybe his locus of grandiosity, his grandiosity would be that he is a good person, that he is charitable, that he is helpful, that is a good member of the community or the collective, we call this pro-social narcissism. So society and culture dictate how the narcissism and the borderline would be manifested in women and men. And this is the main constraint. But as far as the psychology, it's identical. There are no differences.
Then both narcissists and borders can control their behaviors when there are consequences. Then they know how to control their behaviors.
No, borderlines cannot actually. But narcissists can. Borderlines cannot control their behaviors. They are what we call impulsive. The impulsivity in borderline is so big that the borderline is unable to take into account the consequences of her actions and so on and so forth, and she just acts. She is impulsive, as we call it, and that's why borderlines are considered to be reckless. In other words, they act in ways which endanger themselves as well as others. So they would engage in unsafe sex, or they would drink too much. Substance abuse is very common in borderline, because there is an element of recklessness, an element of a kind of variant of self-harm and self-destructiveness. So borderlines cannot, but narcissists definitely can and do adjust or control their behaviors according to the setting. So we know, for example, that narcissists in total institutions. Total institution is a place where you have to spend all the day and all the night. You cannot leave the place. So total institution is a prison or hospital or the army, these kind of places. So we know that in total institutions, narcissists, people diagnosed with narcissistic personality disorder, lose all the narcissistic behaviors. They don't show a single narcissistic behavior. Because in prison, if you behave in a narcissistic way, if you're contemptuous, if you're entitled, if you're disempathic, if you are aggressive, you're dead. Simply dead. Suddenly the narcissist is the nicest person.
Then they know what they do. Then they know what they do.
It's clear that narcissists can control and modify their behaviors at will. They definitely can, and they just don't care to do that. They don't care enough to do that. However, we should not confuse behaviors with internal dynamics. The dynamics of narcissism, for example, the motivation, why to do something, all these are intact. They're untouched. They cannot be cured or healed or changed, or they're fixed for life. They're lifelong. These are not affected by the environment. These. But the behaviors, definitely. We also know that in therapy, we have great success at modifying in all kinds of therapy, in schema therapy, to some extent CBT, Gestalt. We know that in many treatment modalities, we are pretty successful at convincing the narcissist to eliminate or to reduce or to modify abrasive behaviors, antisocial behaviors, unpleasant behaviors, socially unacceptable behaviors. We do it very frequently, very often. For example, if the narcissist is afraid to lose his family or all his money or his reputation or his position, the overwhelming majority of narcissists would modify their behaviors. Even behaviors that lasted for decades, even behaviors that became the hallmark or the badge of the narcissist, that he is known for these behaviors. But he would flip on a coin and the behaviors would be gone. So yes, there is control in narcissism.
Which disorder is easier to diagnose?
Borderline is a lot easier to diagnose. A lot easier, but both disorders, within a few sessions, 3 to 5 sessions with the patient, both disorders can be diagnosed safely. So it's not like it's something that would take years or decades to diagnose it. It's these are pretty visible disorders. It's I mentioned many elements that are common to borderline and not common in narcissism. In narcissism also we don't have suicidal ideation. Narcissist is not suicidal. Narcissists do not self-harm. They do not mutilate or cut themselves or whatever. However, when a narcissist goes through extreme stress, collapse, or narcissistic mortification, the narcissist suddenly begins to resemble a lot a borderline patient.
Mood disorders.
Borderline. He begins to resemble a lot the borderline patient. So he loses the defenses. And when he loses the narcissistic defenses, what remains under it is the borderline. So there is an affinity between borderline and narcissism. And one could say that narcissism is a kind of repressed borderline, suppressed borderline. Narcissism could be described as a series of techniques and strategies to mitigate or to eliminate borderline personality organization, exactly like Kernberg suggested. But on presentation, in a clinical setting, definitely narcissism and borderline are not the same. They should and can be distinguished. Let me have a look if there's something I missed. Yes, one thing maybe. That is psychosis. Psychosis and other self-states. When the narcissist and the borderline are exposed to pressures and stresses that they cannot manage, which increase the anxiety and make the anxiety overwhelming and so on, both of them sometimes develop psychosis. The psychosis is very brief, could last a few minutes, a few hours, maximum 3 or 4 days, and this is known as psychotic micro-episodes. So they have this psychotic reaction to stress. But before they reach this final stage of psychosis, they go through transformations. The narcissist becomes borderline when under stress, and the borderline becomes secondary psychopath. So when you pressure a borderline, threaten her, abandon her, humiliate her, reject her, she is likely to become highly psychopathic.
She won't feel remorse, or
she would become psychopathic in the sense that she would be defiant, she would be aggressive, she would be reckless, she would be contumacious, she would reject authority and so on. But I didn't say primary psychopath. A primary psychopath does not experience regret or remorse. A secondary psychopath does. So a secondary psychopath is a psychopath who has emotions and empathy. So the borderline becomes a psychopath behaviorally, but emotionally she still retains the capacity for emotions and the capacity for empathy. So
borderline has empathy?
Borderline, we used to think that borderline has empathy like healthy people, or even more. But today we know that borderline has empathy, but it's very reduced. We did discover, however, pretty recently, that borderline has cold empathy, exactly like narcissist and psychopath. A borderline is able to scan you, immediately discover your weaknesses, vulnerabilities, fears, and so on, vectors of attack. And she would use this, but she would use this information not like the psychopath. The psychopath would use this information to get your money or to have sex with you. The narcissist would use this information to convert you into a source of narcissistic supply or participant in the shared fantasy. The borderline would use this information to make you into her intimate partner or special person. So that she can obtain the succor and the support and the love and the intimacy and so on that she's looking for.
Manipulation, a bit.
All these interactions involve manipulation. The most extreme form of manipulation is codependency. In codependency, the codependence message is, I can't manage without you. I can't live without you. I can't accomplish things without you. I need you. Neediness is the core of codependency, clinging. And that is, of course, highly manipulative. It's what we call control from the bottom. The codependent controls you by being submissive. there's no form of control more extreme and pernicious and insidious than submissiveness. When you're submissive, you're totally in control. When you have a family member who is constantly sick, you know, and you would feel obligated to be there, to help, and you would never leave this person, because if you leave her, she would die. So it's control, it's manipulation. Submissiveness is a form of control. Anyone who engages in BDSM, BDSM is a kind of sex, yes? Sadomasochistic sex. Anyone would tell you that the person who is really in control in the BDSM sex is the submissive, not the dominant. The submissive person is in control. The dom or dominant person is just doing what the submissive wants. Submissiveness is a major form of control. Codependents use it. Some borderlines use it. Some borderlines play the submissive. It's very difficult for borderline to play the submissive because she's grandiose.
Because she wants to be the boss, but
she's grandiose. She thinks she's superior. She thinks she's... So it's difficult for her. A borderline who is submissive is faking, acting. So that's the difference between borderlines and...
It's a form of manipulation also.
Yes, but intentional. Whereas in codependency, the codependent is submissive and it's not intentional. It's who she is. It's her nature. You know? But in borderline, it's not her nature. She is faking it. Because the real core of borderline is as grandiose as a narcissist. Borderline is as grandiose as narcissist. Exactly. Maybe sometimes more. So that's why borderlines and narcissists often come together. Because the affinity, the closeness, there's a huge psychological closeness between narcissists, and they resemble each other very much. And they give each other a perfect solution.
Yeah, their needs are
compatible. The borderline is looking for a strong, self-confident person who would regulate her, control her. That's the narcissist's wet dream, to control someone, you know. So narcissist loves it. He's in control, he's in charge, he's the master, he's this. And she feeds the narcissist. She tells you, you're amazing, you're incredible, you're this, you're irresistible, you're genius. And the narcissist experiences narcissistic elation. She becomes a drug. The borderline becomes the drug of the narcissist and fulfills all his needs. So she weaves, she creates the exact shared fantasy that the narcissist wants. The narcissist, on the other hand, also caters to the needs of the borderline. It's also very good for the borderline because narcissists are good at regulating other people externally. Narcissism, pathological narcissism, is about regulating other people from the outside. If the narcissist wants you as a source of narcissistic supply, he would manipulate you psychologically, he would regulate you psychologically externally from the outside so that you give him supply. So they are the masters of fantasy, narcissists are the masters of fantasy, and the masters of external regulation, which is exactly what the borderline has been looking for all her life. You know. That also explains current political realities, because people all over the world, can't survive in reality anymore. Reality is too much for them.
Yes.
Everyone is looking now, everyone. There's no country, to best of my knowledge, that is an exception. Everyone now is looking for a fantasy. And who is the world's leading authority on fantasy? The narcissist.
Yeah,
so if you're looking for fantasy, naturally you would have narcissistic leaders, and narcissistic intellectuals, and narcissistic scientists, and narcissistic everything. Because they can give you the perfect fantasy. They've been doing it since age 3. You know, they're building fantasy. They're the experts. And so, and of course, because everyone, and now I'm talking about collectives, huge collectives, nation states, and I'm talking about the totality of humanity, because all humanity now is looking for fantasies.
Yes.
Narcissists rise to the top and they give the fantasy, but then that means that the other side becomes borderline.
Then the society becomes borderline.
Because society becomes more and more borderline. Because this is the natural combination. Narcissist, borderline.
That's why societies are so angry now.
Angry, labile, up and down the mood. aggressive.
Aggressive, yes.
These are all
Wild.
borderline features. Suicidal. People are drinking much more, doing drugs much more, committing suicide much more.
That's right.
And so on. Suicide went up 4 times, 5 times in certain age groups. So we're becoming more borderline all the time. And we're becoming more borderline because the organizing principle nowadays is fantasy. And in charge of fantasy are the fantasy makers, the geniuses of fantasy, narcissists. Again, not only in politics, in science. I see fantasy definitely in science. I've been a scientist all my life, since age 9. I see fantasy in science now, in physics, in biology, in neuroscience, of course. Neuroscience is 90% fantasy. Physics now is 70-80% fantasy. Nothing to do anymore with reality. Nothing. In physics today you have theories that are completely divorced from reality, like string theory. Similarly in neuroscience, they live in fantasy. They find one neuron or one gene and immediately they declare that they decoded the human mind. This is fantasy. When you make grandiose claims, exaggerated claims, it's the major clinical sign for fantasy. Major. When you go to a neuroscientist and the neuroscientist tells you, or geneticist, and the geneticist tells you, I found the gene for gambling. That minute you know, this guy lives in fantasy. That minute you know it. Because gambling is a super complex behavior with multiple layers and so on. Yes, of course gambling would be connected to the genes. The genes are the hardware. But probably to hundreds of genes or thousands of genes working together. Anyone who makes a claim that they found the gene for gambling, and I'm kidding you not, such a claim was made, this is a person who lives in fantasy. And today, 90% of the claims are like that. 90%. And there are other fantasies, like if you were traumatized, you can pass it through the genes to next generation. That's complete fantasy. Today, everything is fantasy, in science, in politics, in cinema.
Why human needs fantasy?
Sorry?
Why human beings need fantasy?
Because the alternative sucks. Reality is unbearable, intolerable, unacceptable, frustrating, crushing. Crushing.
And and in the society, when we see bad people, we think that they are all disordered. Can a person be evil and he or she can't have disorder also?
The vast majority of, I don't know what is evil, but the vast majority of abusers, for example, don't have any mental health disorder. It's about control, about power.
They call all bad people that he can be narcissistic or psychopath or border.
No. A small minority are. The vast majority of people who are antisocial, or people who are self-interested, egotistical, people who are abusers, and so on and so forth. There's nothing, no mental health condition of any kind, not only personality disorder.
Pure evil. Just.
Someone may be emotionally invested in control and power. So this kind of person would abuse people. In domestic violence, for example, there have been many studies about domestic violence, Bancroft and many others, and consistently we found that domestic abusers, people who beat up women and children, they don't have any mental illness.
Just anger issues.
Anger issues, control. Control was the main thing. Power. It's a power play. Same with rape. Majority of rapists are mentally healthy, completely mentally healthy. It's just about power. It's a power play, And the more society is organized around the concept of power, the more it legitimizes abusive behavior. So now you have abusive political leaders, abusive, media figures. You have abusive influencers, like maybe Andrew Tate. You have this kind of people where abuse is, and now you have abuse openly in the United States as a principle of government. So again, there are massive social and cultural influences, and they are much more important than mental illness.
Yes,
I think so. Among bad people, as you call them, or power-hungry people, controlling people, and so on and so forth. Culture and society are much more important components than, and of course we have a perfect experiment that is Nazi Germany, where in Nazi Germany, 3 million people out of a population of about 55 million adults, 3 million people joined the SS, which was an evil organization. If ever was an evil organization, it's the SS. 3 million people joined. You can't say that all of them were mentally ill.
Yeah.
And there has been a study by Goldhagen of the psychological profile of the people who executed the Jews in concentration camps, in the gas chambers, and executed them with a gun. So he studied their psychology, and he discovered that almost all of them
Normal.
totally normal. They were accountants and lawyers, and they had families, and they had dogs, and they played music, and they were all totally normal. He couldn't
they
find
can
actually.
just crave power because of this. They maybe attend or
No,
volunteer.
in their case, it was the influence of the culture and society. They didn't crave power. They were normal people.
It's sadistic.
No, they were not sadistic. They were told by culture and society that this is the right thing to do. So they did. They were told the Jews are enemies, the Jews are dangerous, and there's a threat to Germany, and you should kill them. So they killed them.
It's so easy to control people or manipulate.
Yes, it's easy to control people because people have many, many needs that are unmet, repressed, ignored. If you have the right equipment, you can detect what people need.
Yeah.
And then you can tell them that you're going to give them what they need. You don't have to give them. You just have to tell them that you will give them. And that moment you create an addiction. And you're in full control from that moment. It has nothing to do with mental illness. Of course, you have, mentally ill people like narcissists, psychopaths, sadists. You have. And
What
they
is
are
the
also
percentage
bad people.
in a society, for
Sorry?
example, personally disordered people, percentage in the society?
Wow.
But you cannot
less,
diagnose
a lot
because
less.
they don't come to therapy generally.
No one comes to therapy.
Yes,
It's a common. No one comes to therapy. Not only narcissists. Borderlines don't come to
Yes.
therapy. Psychotic people don't come to
Then
therapy.
how can you know the percentage?
Okay, so we have statistical tools that allow us to learn from those who do come to therapy, allow us to extrapolate. How do you know who is going to be elected? You make anketa, you make opinion poll with 1,500 people. And from 1,500 people, you learn about 40 million people. Same in psychology.
Then what is the percentage?
We have a small group that do come to therapy, and from this small group we learn about a bigger group. That's why statistics is a crucial tool in psychology. So the claim online that narcissists don't come to therapy, so we don't know how many narcissists there are. It's nonsense. These are people who have no idea about psychology or science, like majority of people online. So we do know exactly how many narcissists there are. We do know exactly how many borderlines, exactly how many psychotic. We know about every mental diagnosis, how many people there are. So narcissists in society, it's probably around 2%. People diagnosed with narcissistic personality disorder. However, there are many more people who have a narcissistic style. Narcissistic style is subclinical narcissism, narcissism that cannot be diagnosed as a disorder. So these are people who are obnoxious, they lack empathy, they're exploitative, they're envious, but they don't. This doesn't amount to a disorder. They don't reach that level of disorder. They don't have, for example, extreme problems with telling the difference between internal and external. They don't have fantasy. People with narcissistic style don't have a fantasy. Fantasy defense is unique to NPD, to the disorder, not to the style. They don't have a false self. Narcissists do. So the ones with the disorder, we are talking between, depending on the period, depending on the country and so on, between 1.7% and possibly up to 3%, depending on the country. The average, the global average is probably around 2%.
2%.
Only, yes. And when you see self-styled experts online saying that 1 of every 6 people is a narcissist, whoever said that has no idea what he or she is talking about. It's an ignorant person.
Then in the society, narcissistic traits rise, not the shared fantasy or the false self, but the traits rise.
There is a rise in narcissistic traits that's been documented by Twenge and Campbell and others. That much is true. I also think there's a rise in narcissistic style, because narcissistic style is perceived nowadays to be positive and leads to positive outcomes. So it's self-efficacious. It's a positive adaptation. In July 2016, the magazine New Scientist, which is a very important scientific magazine, had a cover story: parents, teach your children to be narcissists. So narcissism is becoming, and even in some academic settings, some faculties, including in Cambridge, United Kingdom, where I work, even in these settings, you have people saying that narcissism is a positive thing, the next step in evolution. It's very important. Narcissists are good leaders of the military, the corporate companies, economic companies. Narcissists are good political leaders, and so on. So there is a glorification and glamorization and legitimization of narcissism nowadays, and starting with psychopathy now. Now you have a few academics, Kevin Dutton and others, that say that psychopathy is a great thing, and we would not have survived without psychopaths. And we should put them in charge. We should make them the leaders, because they're much better at making decisions.
And that professors can be psychopath also?
Or, I don't know him personally. But you have an incentive as an academic to say these things, because the people in charge, the people who give you the money, they're all narcissists and psychopaths. So of course, if you say such things, you will benefit. You understand? Even in social activism, in social justice movements, as I mentioned yesterday, narcissists and psychopaths took over these movements. So this is established in studies.
So let's talk about the narcissistic disorder types, so we can see who is who and we can understand better. How many types
for
we have?
generations, there have been attempts to classify narcissists. So initially there was the phallic narcissist, don't ask, many classifications. What is accepted today is that there are at least two types of narcissists. One is known as the overt narcissist, and one is known as the covert narcissist. Both of them are grandiose. Again, people online, so-called experts online, make the mistake. They say that the overt is grandiose. Both of them are grandiose. The only difference is that the covert fails to obtain supply. Is in a constant state of collapse, whereas the overt is good at obtaining supply. That's basically the difference between them. The covert narcissist is passive-aggressive. The main affect, the main emotion of the covert narcissist is envy. Envy defines the covert narcissist. The covert narcissist is a bit more Machiavellian, manipulative, and so on. The overt narcissist is more open, more clear, and so this is the first very critical distinction. The covert narcissist is vulnerable, is shy usually, fragile. The internal structure is very fragile, easy to challenge the covert narcissist, and easy to push the covert narcissist to mortification and narcissistic injury. The covert narcissist is regards himself as a victim of discrimination, or victim of his peers who are envious of him, or victims of society and institutions. So there is a lot more paranoid ideation in covert narcissism, and persecutory delusions and persecutory objects. The covert narcissist is less likely to function well in workplace settings, in society, and so on, so is more likely to be homebound. And in this sense, covert narcissists are more schizoid than overt narcissists. This is today the major distinction made, and that is the only one acceptable to all scholars. Other distinctions, which I will discuss in a minute, not yet accepted by everyone. But this distinction is accepted by everyone. There's only one problem with it. And the problem is that all narcissists are sometimes overt and sometimes covert.
They can shift.
So, yes, so it's not true to say that you are either that or that. It seems that these are states of all narcissists. All narcissists can be this or this. When the overt narcissist fails to obtain narcissistic supply on a regular basis and therefore collapses, he becomes covert. He becomes very vulnerable, very fragile, very hypervigilant, depressed, dysphoric, and then he withdraws. He becomes schizoid. The overt narcissist withdraws from society because it's painful. He cannot obtain supply. So he withdraws and he begins to hate people. He's resentful, he's envious, and he begins to sabotage people and institutions, becomes passive aggressive. And at that minute, that's a covert narcissist.
And he self-supplies.
He self-supplies as an interim stage between overt and covert. But when everything fails, he becomes covert. So overt becomes covert. The covert takes time, recovers, finds new victims, new sources of supply, moves to another location, establishes a new pathological space, and after 7 years, 2 years, 5 years, 6 months, 2 days, he becomes overt. Overt, covert, covert, overt. All narcissists have these phases. We today begin to believe that what happens is the overts and are less likely to be in clinical settings. They're less likely to go to therapy or less likely to be studied by clinical psychologists and so on than the coverts. So we are getting a distorted picture. In clinical practice, the coverts would be overrepresented. In academia, the overts would be overrepresented. So that's why we think that there are two types, but there are not two types. When the overt collapses, there is, for example, suicidal ideation. There is emotional dysregulation, emotional lability. The overt panics. And then it is then that the overt goes to therapy. The overt goes to therapy when they hit rock bottom, when there's nothing left. They lost everything. They lost spouses, they lost children, they lost their money, they were in prison, they are disaster, catastrophe. Then the overt would go to therapy.
Just for depression.
But at that point though, the overt is no longer overt. He is covert. So the therapist would see a covert. While this person only a year ago was totally overt, would never dream to go to therapy. You know? And the academics, they study that person. They study the overt. They never see the covert. Because the covert
never goes.
So they would disagree. The clinicians and the academics would disagree. And that would create the impression of two types, which is not true. Another distinction is one that I invented or came up with between somatic and cerebral narcissists. The somatic narcissist obtains supply by using his body. And as I using his body, it doesn't have to be sex. Could be bodybuilding, could be muscles, could be... But he's using his body, this kind of narcissist. He's using his body to obtain supply. The cerebral narcissist uses his brain, his intellect, his intelligence, intellectual pyrotechnics. The somatic narcissist would be very keen on sexual conquest. He would constantly count how many people he had sex with, or he would measure himself all the time. He would be very involved in his health. He would be either a hypochondriac, or he would have fitness devices measuring all the time how much he's walking. So this preoccupation with the body as a source of supply. The supply doesn't have to be external. It could be self-supply. For example, losing 20 kilos. So he loses 20 kilos and he feels superior. He feels that he had a huge accomplishment. And so this aggrandizes the somatic narcissist. The cerebral narcissist also can self-supply. He could create a YouTube video and he can tell himself, you see what a genius I am? This is genius YouTube video. Yeah.
It's a safe supply, I think.
Yeah, safe supply. Stable at least. So this is somatic versus cerebral. Another distinction that is sometimes made, but I think is very important, is the prosocial versus antisocial. Prosocial or communal narcissist is a narcissist whose grandiosity, whose locus of grandiosity, whose grandiose fantasy about himself, whose inflated self-concept is, I'm a good person. I'm a good person. I'm charitable, I'm altruistic, I'm loving, I contribute to the community and to my country, I am moral, I am more moral than other people, I never lie, I'm this, I'm that. So this kind of narcissist would emphasize pro-social things that society likes and society encourages. And generally speaking, his self-concept or self-image would be a superiorly good person. Not only good, but unusually good person. Unprecedentedly good person. Amazingly good person. Maybe even a saint. A saint. Or maybe even connected to God somehow, on a mission to help people. Gurus.
Then that kind of people collect their supply from giving money to charities.
Yes,
or
charitable, as I said. Yes, they could be charitable, but whatever they do, they advertise it. They make sure that everyone knows, because this is the supply. So this type of people could become gurus, medical doctors, psychiatrists or therapists. They could become
mothers also.
NGO workers. Sorry.
And some mothers are like this.
Some mothers like that, activists. But always the self-concept or self-image as an unusually good person. Not good person, good for everyone, unusually good. Like my morality, I never met anyone more honest than me. You know, you can trust me like you trust no one else. That's the message of the pro-social.
That kind of person can lie?
Yes. But if that person lies, he would say, I'm lying for good cause. I'm lying to help people.
Narcissists have double life. They say they have double life.
No, not all of them. No.
There is a false self that they show and they believe, but there is a life that no one can see behind the closed doors.
No, that's completely untrue. No.
They are just shifting in the mind then.
There's no narcissist, there's only the false self. The narcissist is the false self at home, outside, and so on and so forth. Narcissists, of course, can obtain narcissistic supply differently from different groups, would adapt his behavior. So with some group he would be nice and kind and so on, because that's the way to obtain supply. With the other group he would be abusive and threatening and so on, because that's the way to obtain supply. He would be nice to his family maybe and not nice to his workers, or vice versa. Nice to his workers and not nice to his family. But it will always be about obtaining narcissistic supply, and usually there is a unifying narrative, a unifying principle. The false self has a story, and the story is the narcissist. If the story of the narcissist is, I'm a good person, that would be the story everywhere at all times and so on. And if this kind of narcissist behaves in a bad way, lies or cheats or beats up his wife or is aggressive, or he will invent a story that will explain why he's doing it in a good way. So I am lying because it's good for people. Or I am beating you up because I want to educate you. It's good for you. Tough love. Yeah? I'm verbally abusing you because you're naive and I'm protecting you. You know, this kind of thing.
They can find excuses.
They can always find a way to, but it will always be what we call ego congruent. In other words, it will always support the false self. It will never be ego alien. It will never contradict the false self. So if my false self is I'm a good person, the stories that I will invent as to why I'm doing what I'm doing, they will all support the view that I'm a good person. If my narrative is that I'm a genius, whatever I do will support the view that I'm a genius. Even if I behave in a very stupid way and so on, I will say, they think it's stupid, but I know that it is a genius what I'm doing. You know, always there will be the support of the central narrative in narcissism. And so you have pro-social narcissists. You have, on the other hand, this distinction is the antisocial narcissist, which is by far the most dangerous type of narcissist. But I mean by far, is far more dangerous than psychopath, far more dangerous than narcissist. It's this malignant narcissist, this is known as malignant narcissist, or psychopathic narcissist, antisocial narcissist, is probably the most dangerous person alive. I am not aware of any other disorder which is more dangerous than this. Not sadism, not psychosis, no. This is the most dangerous. Why? Is it combines all the extremely bad elements of narcissism with all the tools of the psychopath. So while the malignant narcissist is actually a narcissist, he has a false self, he has a fantasy, and so on and so forth, he will not use typical narcissistic tools and techniques, which are the tools and techniques of a child. The typical narcissist is a child, is a baby, he's 2 years old, 3 years old. So, it's funny sometimes. You look at the narcissist, you smile. It's like a baby who's doing cute things. So a typical narcissist would manipulate you and abuse you and everything, but he would do it more like a child. And you would see it coming, and sometimes you will forgive. Easier to forgive,
yes.
But not the malignant narcissist. The malignant narcissist is a narcissist, full-fledged, extreme form of narcissist, but he does not use almost any narcissistic technique and tool. Is not a child. He uses psychopathic tools, extreme psychopathic tools. He is cruel, he is callous, he is ruthless, he is aggressive, violently, dangerously aggressive. He hates authorities, contumacious, he is defiant, he is reckless. He couldn't care less about people. He objectifies them, uses them, tramples on them, kills them if necessary. Has no remorse, no regret, no shame, no guilt, no afterthought.
And to everyone, I think.
Not everyone, yes.
To everyone.
Everyone. And this is the kind of person who can easily kill millions of people, or has no problem whatsoever. Erich Fromm, the famous psychoanalyst, in the 60s, diagnosed Adolf Hitler and Joseph Stalin and Mao with malignant narcissism, if you want examples of malignant narcissist. So this is by far the most extreme form. It was described in depth for the first time by Fromm, but the clinical features and everything were described by Otto Kernberg in I think 1975, I'm not sure, in the 70s and 80s. So now we have this malignant narcissist picture. And luckily for humanity, only a very small percentage of narcissists are malignant narcissists. Malignant narcissism is not a comorbidity of narcissism and psychopathy. Not. This is a common mistake online, again. In a comorbidity of narcissism and psychopathy, in other words, when the same individual is diagnosed with narcissistic personality disorder and psychopathy, so there are two diagnoses for the same person, the narcissism is in charge. Narcissism is boss.
Because of the shared fantasy.
Shared fantasy, false self, all the dynamics, everything. So it's actually a narcissist. The psychopath in comorbidity, psychopath comes out when the narcissist is stressed, anxious, humiliated, narcissistic mortification, collapsed. Only in these extreme situations, the psychopathic side of the comorbidity manifests. But that's rare. Someone with narcissism and psychopathy together as a comorbidity, 90% of the time would be narcissist. Classic, regular narcissist. It's not the case with malignant narcissist. Malignant narcissist is not a comorbidity. It's a combination of all the clinical features of narcissist, all the clinical features of psychopath, and all the clinical features of sadist. Malignant narcissist is three.
And paranoia, I think.
Paranoia is outcome in all cluster B. But these three, sadist, psychopath, and narcissist, together, all the time, manifesting all the time. Not that one of them is in reserve, one of them is only for emergency, one of them is for collapse. No. This kind of narcissist is all the time narcissist, all the time psychopath, and all the time sadist. Whatever he does, with his wife, with his children, with his colleagues, he would always be at the same moment narcissist, psychopath, and sadist. So it's not a comorbidity. It's a amalgam. It's a concoction, cocktail that is really terrifying. And luckily, we think that only about 2 to 3% of narcissists are like that. And they create the biggest damage in interpersonal relationships, but also in politics, also in as you heard, Hitler, Stalin.
For example, Hitler's shared fantasy: to save his nation, he must kill millions of people.
Example.
Like
Yes.
this.
Yes. So this kind of person is always a sadist, always. So he would kill these people in sadistic way, and he would.
Without remorse.
But
or-
as a psychopath, he would kill them. As a sadist, he would torture them. As a narcissist, all this will be motivated by a shared fantasy.
shared fantasy.
So everything is operating all the time, all the time. If he has a family, he would create a shared fantasy for the family, but then he would physically abuse his wife, verbally and psychologically abuse his child, sexually abuse his daughter, you know, and then torture all of them all the time. This is the family of malignant narcissists.
Can a malignant narcissist can have a collapse also?
That's more rare in malignant narcissism.
They are more-
Yes, it can. Of course it can, but it's much more rare in malignant narcissism. Malignant narcissism is a defense against a defense against a defense. It's like
They are not fragile, I think.
they're not fragile, exactly. The core is borderline, actually. Then there is narcissistic defense. And then the narcissist, to protect against the collapse, you have psychopathy. To protect against the psychopathy, you have sadism. So it's like layers and firewalls and layers and firewalls. We could say, if you want to look at it that way, that it's the perfect adaptation, perfect evolutionary adaptation, the killing machine, which is untouchable, impermeable, unchangeable, inexorable. It's a killing machine, simply. And of course, you find malignant narcissists among serial killers, among tyrants who kill millions. Among, these are malignant narcissists. When you go to, for example, when you study the chief executive officers of Forbes 500 companies, so there was a study by Robert Hare and Nathan Babiak. They are the two greatest authorities on psychopathy. And they found that among chief executive officers, there are 5 times more psychopaths than in the general population. Other studies found that you have much higher prevalence of psychopaths among surgeons, surgeons, yes, and the military and so on. So, similar studies found that there is an overrepresentation of narcissists in show business and media, the media.
Being a
So,
psychopath doesn't mean that you are going to harm
no,
everyone.
of course not. So that's what I'm saying. That you could have a psychopath, you could have a narcissist, and it would be fully functional and integrated in society and even pro-social and so on. But you cannot have a pro-social malignant narcissist. You cannot. You cannot have a malignant narcissist who would build things. He would build in order to destroy. And he would destroy in order to harm people, in order to cause them pain.
He is aware of
He
that.
thrives on pain. The real narcissistic supply of a malignant narcissist is the pain of other people. He is like a vampire of pain. Whereas a narcissist would take away your energy and a psychopath would take away your money, a malignant narcissist would take away your pain. And he thrives on it. It elevates him. You know, in Slavic mythology, you have mythological characters like Koschy and Veles and so on. And these demonic entities, they thrive on pain. They cause pain to people and it makes them come alive and so on. That's in Slavic, classic pan-Slavic mythology. And so the malignant narcissist is this. And when people say narcissists are demons and I don't know,
That one is a demon. I
yes,
think.
if anyone comes close to this kind of description, it would be the malignant narcissist. Yeah.
Okay. Then in the next podcast, we are going to talk about the no contact. And for the abusers, we are going to talk about the healing. And thank you very much.
Thank you for having me.